Hello everyone. Today's topic is development of GIT, that is gastrointestinal tract, introduction and development of foregut. So this is part 1 of the development of GIT, where we will be seeing development of foregut. Now small revision about general embryology. So as you know, commonly used terms, gestation, it is period of full development of a fetus in utero. It can be subdivided into pre-embryonic stage, that is first 2 weeks of prenatal development, embryonic stage, which is during the 3rd to 8th week, and fetus, which is from 9th week of gestation until birth. So pre-implantation embryonic development, here you can see what is conceptus. So conceptus is zygote and associated membrane following the fertilization. It continue to project towards the uterus by peristalsis and the beating cilia. The zygote undergo 5 to 6 rapid mitotic cell division. You can see there are first 2 cell, then 4 cell, then 8 cell, and each cleavage result in more cell but does not increase total volume of conceptus. So you can see here the conceptus is of same size, but there is continue mitotic cell division is happening, and each daughter cell which is being produced, it is known as blastomere, which is produced by the cleavage. Approximately after 3 days of fertilization, there is 16 cell stage, which is known as morula, and cells are compacted and they look more like a solid mass. They float freely for several more days, but they still continues to divide. The next stage is blastocyst. It is approximately 70 to 100 cell stage, and now the blastocyst starts to secrete fluid, and the cells are organized around the fluid-filled cavity that is known as blastocele. So here is the blastocele, which is fluid-filled cavity, and which is divided by which is surrounded by the cells of the blastocyst. Now here the few cells which are going to form the embryo, they will form the inner cell mass, and the cells which are forming the outer shell, they are known as trophoblastic cell, and they are going to form the chorionic sac and the fetal portion of the placenta. So you can see the blastocyst here having 2 different type of cells, the cells which are forming the outer shell, that is trophoblast, and this is the inner cell mass, and this is the cavity which is known as blastocele. Now here if you see, this is the compact blastocyst, and here the cavity appeared, and then there will be hatching of the blastocyst, and this the one which is coming out, it is known as the hatched blastocyst. So inner mass of embryonic cells, they are totipotent. Totipotent means potential to differentiate into any cell type. This totipotency lasts for few days, and the cells fates are set as being precursor to specific lineage of cells. Now as the blastocyst is being formed, the trophoblast excretes enzyme that begin to degrade the zona pellucida. So here is the zona pellucida, and there will be process of hatching. Hatching means the conceptus is breaking free the zona pellucida in preparation for implantation. Till this blastocyst is covered by the zona pellucida, the implantation does not happens. When this blastocyst breaks the zona pellucida and it is hatched, hatched means it is coming out of the zona pellucida, then only it will be able to go for implantation. What is implantation? It is happening here at the first end of the first week, that means 6th to 7th day post fertilization. It is the process of blastocyst meeting the uterine wall and adhering to it, and then later emptying itself in the uterine lining via the trophoblastic cells. So here is the blastocyst, which is now not covered by the zona pellucida. So now it is ready for implantation. So first it will meet the uterine wall, it will adhere with the uterine wall, then it will go inside the uterine wall. Okay, so that is known as implantation, and this implantation is the end of the pre-embryonic stage, and it can be accompanied by minor bleeding. Typically implants in fundus of uterus or on the posterior wall of the uterus. So these are the common site of implantation. Now second week of intrauterine life. So at the beginning of second week, that means 8th day, the cells of the inner cell mass forms two-layered disc of embryonic cells. So these two-layered embryonic cells are present here. They are forming the embryonic disc. Here the layer which is facing the blastocele or the blastocyst cavity, they are known as hypoblast, and the one which are facing opposite, they are epiblast. And here there is appearance of one cavity which is known as amniotic cavity, which is present here between the epiblast and the amnion. So the cells from the upper layer of the disc, which is known as the epiblast, these cells which are covering the amniotic cavity, they are known as amnion. They are forming the amnion. Amnion is filled with the amniotic fluid, and eventually it is going to become the embryo. Now here, as I told you, in the second week there is formation of bilaminar germ disc. Bilaminar germ disc means we are talking about the embryonic cell mass, and these outer cells are the trophoblastic cells. So within this embryonic cell mass there is appearance of amniotic cavity, and the outer layer of the bilaminar germ disc is the epiblast, and the inner layer is hypoblast. So on the ventral side of the embryonic disc, which is bilaminar, here which are forming opposite the amnion, these cells in the layer of the embryonic disc, these are forming the hypoblast, and they are forming the primitive yolk sac. So yolk sac is supplying the nutrient absorbed from the trophoblast, and they are providing primitive blood circulation to the developing embryo for second and third week. So you can see here we started with conceptus, then there was repeated mitotic cell division. So there was morula, then there was blastocyst, and then within the blastocyst there was appearance of the cavity which is known as blastocele, and then implantation happened, and following the implantation this bilaminar germ disc appeared in the second week, where two layers are there, one is epiblast, one is hypoblast. There is appearance of amniotic cavity, there is appearance of exocoelomic cavity or primitive yolk sac. Now here if we see the bilaminar germ disc, so here the placenta is taking over the nourishing embryo at the 4th week, and yolk sac is greatly reduced in size. The primitive yolk sac is greatly reduced in size, and here the main function is to serve as a source of blood cells and germ cells, the cells which will give rise to form the gametes. Now coming to the 3rd week, which is known as gastrulation. So now the two-layered germ disc which we have seen already, consisting of epiblast and hypoblast, now it will become 3-layered disc through a process of gastrulation, and the cells which already were totipotent, now from totipotent they will become multipotent. Difference is totipotent means they can become any type of cell, they can make any type of cell, but multipotent they can make multiple type but not all the type. Now embryo is going to take the shape of an oval shaped disc. You can see here this is an oval shaped disc, and it forms an indentation. So this is known as primitive streak along the dorsal surface of the epiblast. So you can see here, this is the epiblast, this is the hypoblast, and here on the dorsal surface of the epiblast there is appearance of primitive streak, and a node at the caudal end or the tail end of primitive streak emits growth factor that directs cells to multiply and migrate. So here is the primitive streak, and you can see the node at the tail end of the primitive streak. Okay, so that will be releasing the growth factors. Now during the gastrulation, the cells migrate towards and through the primitive streak and more laterally create two new layers of the cells. So you can see here, that is epiblast. From here the cells are going downwards and laterally. So the first layer which they are going to form, that is endoderm. These are the sheet of cells which displaces hypoblast, and now they are going to lie adjacent to yolk sac. And the second layer, which is known as middle layer, which is going to form the mesoderm, and the cells of the epiblast that remain behind, that not migrated through the primitive streak, they are going to form the ectoderm. So we have seen the bilaminar germ disc where only two layers were there, epiblast and hypoblast, and here in gastrulation all the three layers are formed: endoderm, mesoderm and ectoderm. And remember, all the three layers, ectoderm, mesoderm and endoderm, originated from epiblast. Hypoblast does not have any role in forming the three germ layers. So you can see here the third week of intrauterine life, which is known as gastrulation. So it has formed endoderm, mesoderm and ectoderm. Endoderm is going to form the digestive system, liver, pancreas, lungs, the inner layers. Then mesoderm is going to form the circulatory system, the lungs, the epithelial layer, the skeletal system, muscular system, and ectoderm is going to form the hair, nails, skin and the nervous system. Now coming to the fourth week. So we can see at the end of the third week, gastrulation happened, formation of three germ layer happened, and also there was formation of neural tube. The process is known as neurulation. And in the 4th to 8th week, now organogenesis will happen and the embryonic folding will happen. So from 4th to 8th week of intrauterine life, folding of embryo happened. Now the significant event in establishment of the primitive form of the human body, the flat embryonic disc which we saw at the time where it was a bilaminar germ disc, now it going to become cylindrical embryo in 4th to 8th week, and folding occurs both in median and horizontal planes due to rapid growth of embryo. So folding of embryo in median plane, that is craniocaudal direction, progressive increase in length of embryo happens. Then head and tail end remain close together, embryonic disc bend producing a convexity dorsally and bulge upwards into amniotic cavity. You can see here the convexity is there. There is increase in length, head and tail end gets folded on itself to form head fold and tail fold. So there is a appearance of head fold and tail fold, and as a result of formation of head and tail folds, the head and tail ends of the embryo move ventrally. So you can see here ventrally there is head end and the tail end. The folding of embryo in the median plane, so here the part of yolk sac becomes enclosed within the embryo to form a long tubular structure called primitive gut. So you can see here this is primitive gut. So the primitive gut forms most of the GIT, the gastrointestinal tract. The primitive gut can be divided into foregut, midgut and hindgut. The midgut is communicating with the yolk sac through wider channel, which is known as primordium of ventral duct or yolk sac. So the yolk stalk. So in front of the yolk stalk is known as midgut, proximal to that is foregut, and distal to that is hindgut. Okay, so the foregut is separated from the stomodium where the future mouth will be formed. There is a membrane known as buccopharyngeal membrane, and the hindgut will be separated or from the proctodium, the future anus. So here it is separated by cloacal membrane. The folding of embryo here, as I have already told you, this is vitellointestinal duct or yolk stalk, and there is one another small diverticulum is arising from caudal part of the yolk sac, and it is going to grow into the connecting stalk attached to the caudal end of the embryo. It is known as allantois or allantoid diverticulum. So this is the folding of the embryo in median plane. Then folding of embryo in horizontal plane, that is known as lateral folding. So here the folding of embryo forms a right and left lateral folds. Lateral folds, you can see right and left lateral folds. Now they move medially and fuse to each other to form anterior abdominal wall. So they are going to fuse here. They are going to form the anterior abdominal wall. In the center of anterior abdominal wall, a circular aperture remains. This represents the future umbilicus. The formation of lateral fold in embryo, communication between midgut and yolk sac narrow to form vitellointestinal duct or omphalloenteric duct. So you can see here, this is the vitellointestinal duct or omphalloenteric duct. So because of this lateral folding, as embryo is folding on itself, amniotic cavity expanding enormously and completely surrounding the embryo. You can see here, this is the amniotic cavity and this is the yolk sac, and the lateral folding in such a way that this amniotic cavity is going to increase and increase so that it will completely surround the embryo. You can see here it has completely surrounded the embryo. Embryo free float in the amniotic fluid within the amniotic cavity, and so this amniotic cavity is acting as a swimming pool for the embryo. Due to enormous expansion of the amniotic cavity, extraembryonic coelom now is getting completely obliterated. So this is the extraembryonic coelom. This is completely obliterated and amnion is forming the covering of the umbilical cord. So here is the lateral folding is completed. So effect of folding of the embryo. So because of folding of the embryo, flat embryonic disc becomes cylindrical with an opening on the ventral aspect, that is known as umbilical ring. Ectoderm forms the outer covering of the embryo. Embryo completely surrounded by the amniotic cavity. Part of yolk sac gets incorporated in embryo to form primitive gut. Cranial end of primitive gut separated from stomodium by the buccopharyngeal membrane I have mentioned here. And also the caudal end of the primitive gut, you can see here, it is separated from the proctodium by cloacal membrane. The connecting stalk or connected stalk, which is going to form the umbilical cord, now becomes attached to the ventral aspect of the embryo around the umbilical opening, and allantois also gets connected to the terminal part of the hindgut. Head containing the brain forms the cranial most part of the embryo. So here will be the brain, and the septum transversum and pericardial cavity lie on the ventral aspect of cranial end of the embryo, heart tube lying dorsal to the pericardial cavity, that you will see later. Okay, so you can see here, this is the septum transversum, and here is the pericardial cavity, and here is the developing heart. But because of the folding, you can see here, this is the developing heart, or we can say the heart tube, which is lying dorsal to the pericardial cavity, and here is the developing neural tube, which is going to form the brain and the spinal cord. The septum transversum is present here. So this septum transversum is separating the cavity here, the pericardial cavity here, from the midgut. A depression formed between the head bulge and the pericardial bulge, which is called as stomodium. So here is the stomodium where the future mouth will form, and it is separated from the cranial end of the foregut by buccopharyngeal membrane. Two half of the perineal cavity fuse to form a single peritoneal cavity. So now that is the effect of folding. Now coming to the development of GIT. So as we know, the digestive tract or gastrointestinal tract developed from the primitive gut. You can see here the primitive gut, which is divided into foregut, midgut and hindgut. So primitive gut formed during the 4th week of intrauterine life by incorporation of larger portion of the yolk sac into embryonic disc during craniocaudal and lateral folding of the embryo. Primitive gut extends from the buccopharyngeal membrane to the cloacal membrane. So you can see here from the buccopharyngeal membrane to the cloacal membrane. But this primitive gut is freely communicating with the remaining yolk sac. Here this is the yolk sac by the vitreointestinal duct. The part of the gut or GIT, developing GIT proximal to this communication is going to form the foregut, and distal to that is hindgut, and the part which is intervening here, that is midgut. The cranial end we have told already. Here is the buccopharyngeal membrane which is separating the cranial end of the foregut from the stomodium, and cloacal membrane is separating the distal end of the hindgut from the proctodium. At later stage of development, buccopharyngeal and cloacal membrane will rupture, and the gut will communicate to the exterior at the both ends. Muscular connective tissue and other layer of wall of digestive tract are derived from splenophilic mesoderm surrounding the primitive gut. While primitive gut is being formed, there is a midline artery, dorsal aorta, which gives off a series of ventral branches. So there is an artery which is going to supply the foregut, which is known as celiac trunk. There is an artery which is going to supply the midgut, that is known as superior mesenteric artery, and the artery which supply the hindgut is inferior mesenteric artery. So in region of midgut, arteries run right to the yolk sac and termed as vitelline arteries. Later most of the ventral branches of dorsal aorta disappear only. So these three branches, that is celiac trunk, artery of foregut, superior mesenteric artery, artery of midgut, and inferior mesenteric artery, artery of hindgut remains. So the derivative of foregut, midgut and hindgut. So here is the summary. Foregut is going to form the floor of the mouth, tongue, pharynx, a derivative of the pharyngeal pouches, thyroid, part of thyroid, respiratory system, esophagus, stomach, proximal or the upper half of the duodenum. Midgut is going to form liver, pancreas, extrahepatic biliary system, distal or lower half of the duodenum, jejunum, ileum, ascending colon, and right 2/3 of the transverse colon. Hindgut is going to form the left 1/3 of transverse colon, colon, descending colon, sigmoid colon, rectum, upper part of anal canal. So what is anterior and posterior intestinal portal? Anterior intestinal portal is present between the foregut and the midgut. So here is the anterior intestinal portal. Its position in adult gut corresponds with the termination of bile duct in the second part of duodenum. Then there is posterior intestinal portal, which is the junction between midgut and hindgut, and its position in adult guts corresponds with junction of proximal 2/3 and distal 1/3 of transverse colon. So here is posterior intestinal portal, and here is anterior intestinal portal. Now development of foregut derivative. First, esophagus. So esophagus develops from part of foregut between pharynx and stomach. Ventrally at the pharyngo-esophageal junction, foregut present a median laryngeotracheal groove. So here you can see there is laryngeotracheal groove in the pharynx, and this groove bulge forward and caudally to form tracheobronchial or respiratory diverticulum. So here is, because of this groove, so proximally there is tracheobronchial diverticulum, and here is the remaining of the pharynx, which is going to form the esophagus. So tracheoesophageal septum divides foregut caudal to the pharynx into esophagus and trachea. Here was the groove, and here was the appearance of tracheoesophageal septum, and because of this septum, now the proximal part separated, which has formed the laryngeotracheal tube, which will form in future the larynx and trachea, and this dorsal part is going to form the esophagus. So initially esophagus is short, here it is short, but later it elongates due to formation of neck, because of descent of diaphragm and because of descent of heart and lungs. So initially The lumen of esophagus is almost obliterated here by proliferation of endodermal cells. These cells later break down and esophagus is recanalized. The lining epithelium is formed from the endoderm of the foregut. The musculature and the connective tissue are formed from the splanchnic mesenchyme surrounding the foregut. In that, upper 1/3 consists of striated musculature, middle 1/3 consists of mixed, that is striated and smooth musculature, and lower 1/3 consists of non-striated or smooth musculature. Now, congenital anomalies of the esophagus. First one is esophageal atresia. So here, due to failure of recanalization of developing esophagus, so because of this there is also possibility of tracheoesophageal fistula due to extreme posterior deviation of tracheoesophageal septum. Here, fetus unable to swallow the amniotic fluid. Abnormal increase in amount of amniotic fluid will produce polyhydramnios. Newborn with the esophageal atresia accept first feed, but that is milk or fluid diet normally, but when the given subsequent feed, it regurgitates through the mouth and nose and may cause respiratory distress and cyanosis, and the treatment is surgical correction, which gives 85% of survival rate. So atresia means there is no formation of esophagus. So you can see here there is no formation of esophagus, but there is formation of fistula of the developing esophagus with the trachea. Esophageal stenosis. Stenosis means lumen of esophagus becomes narrow. Usually it is in the lower third part of the esophagus. It is caused by incomplete esophageal recanalization and vascular anomalies. Depending upon the grade and extent of stenosis, symptoms may be mild or severe, and in severe cases, symptoms are similar to esophageal atresia. Then there is tracheoesophageal fistula. So as I mentioned, it is due to failure of separation of tracheoesophageal diverticulum from esophagus due to non-formation of tracheoesophageal septum. So here there is a communication is formed between the esophagus and the trachea. So in most cases, lower segment of esophagus communicates with the trachea. Clinically, it is present as infant vomit every feed that he or she is given. Presence of air in stomach is diagnostic sign of tracheoesophageal fistula. So you can see here, this is a normal anatomy. Here there is atresia of esophagus is there, and there is distal tracheoesophageal fistula. Here there is atresia along with proximal and distal tracheoesophageal fistula. Here there is atresia with proximal tracheoesophageal fistula. Here there is no fistula but only atresia. Here there is only fistula but no atresia. So there is still communication is persisting between esophagus and the trachea. Then there is achalasia cardia. It is due to failure of relaxation of musculature in lower part of esophagus following loss of ganglion cells in orbex plexus. Clinically, patient complains of difficulty in swallowing, and when you take a barium swallow image, the lower part of esophagus present pencil shaped narrowing, which is also known as bird beak deformity. Now, development of stomach. So stomach is appearing as fusiform dilatation in foregut distal to the esophagus in 4th week of intrauterine life. Dilatation presents. So here when you see that because of this dilatation, there is ventral border and dorsal border. There is a left surface and right surface. There is upper end and the lower end. So you can see there is upper end, there is lower end, okay, and there are two border, which is ventral and dorsal, okay. So to the ventral border, ventral mesentery is attached. To the dorsal border, there is dorsal mesentery is attached, and there is left surface, right surface and left surface. Dorsal border is provide attachment here to the dorsal mesentery, and ventral border provide attachment to the ventral mesentery. So the dorsal mesentery, which is also known as dorsal mesogastrium, extend from stomach to the posterior abdominal wall, and ventral mesentery of the stomach, which is also known as ventral mesogastrium, it extends from stomach to septum transversum and anterior abdominal wall. Changes in shape of stomach. So as I mentioned in beginning, stomach is a fusiform dilatation having upper end, lower end, having ventral border, and this is the dorsal border having the right surface and left surface. Now changes in shape due to differential growth in different regions. So dorsal border grows much more than the ventral border. So you can see here, this is the ventral border and behind is the dorsal border. So the dorsal border is growing more, okay, and ventral border is growing less. So dorsal border forms the greater curvature of the stomach and ventral border forms the lesser curvature of the stomach. So these changes in the shape is occurring due to differential growth in different regions. Now change in shape of stomach also because of rotation. So there are two rotation, one is around the longitudinal axis and another one is around the antero-posterior axis. So because of rotation around the longitudinal axis, now the ventral border comes on the right side, okay, and the dorsal border comes on the left side. And we already saw the ventral border was forming the lesser curvature and dorsal border was forming the greater curvature. So this rotation is happening around the longitudinal axis, and now because of this longitudinal the rotation around the longitudinal axis, now the ventral border became the right border, which eventually is going to form the lesser curvature, and the dorsal border became the left border, which is going to form the greater curvature. And we have already seen the right surface, because of this rotation around the longitudinal axis, it went on the posterior aspect, so now it became posterior surface, and the left surface came on the anterior surface, so it became the anterior surface. Now there is another rotation around the antero-posterior axis. So around the antero-posterior axis, because of that, what happens, the upper end goes away on the left side and lower end goes towards here on the right side. So these two rotations are happening. Now you can see here there is the ventral border and dorsal border, and there is a right vagus nerve which is supplying the right surface and left vagus nerve which is supplying the left surface. This is happening because of before the rotation. So now because of the rotation, this ventral border has come on the left surface and the dorsal border came on the right surface. At the same time, the right surface now has become gone on the posterior surface, and the left border has come on the here, the left surface has come on the anterior, okay. So because of rotation around the longitudinal axis, the first stomach is rotating around 90 degree clockwise around its longitudinal axis. As a result, the left surface now became anteriorly and it is going to form the anterior surface. The right surface gone posteriorly to form the posterior surface. For this region, left vagus nerve, which was initially supplying the left surface, now supplying the anterior surface, and right vagus nerve, which was supplying the right surface, now it is supplying the posterior surface. So this is because of rotation around the longitudinal axis. Now rotation around the antero-posterior axis, so the upper end or the cephalic end, the lower end or the caudal end, they originally are lying in the midline, but because of rotation around the antero-posterior axis, the cardiac end, the upper end of the stomach, the cephalic end of the stomach, which was originally lying in the midline, now it is moving towards the left and slightly downward, and the pyloric end or the caudal end or the posterior or the lower end of the stomach, which was originally in the midline, now gone slightly on the right side from the midline. Now changes in the mesenteries of the stomach due to rotation. As I have already told you, there is ventral mesentery of the stomach, which is known as ventral mesogastrium, and dorsal mesentery of the stomach, which is known as dorsal mesogastrium. So initially ventral mesentery of the stomach extends from the lesser curvature to septum transversum and anterior abdominal wall. But when liver is here, when liver is developing between the within the ventral mesogastrium, so the ventral mesogastrium is divided into two parts. The ventral mesogastrium between the stomach and the liver is known as lesser omentum, and the part of the ventral mesogastrium which is attaching the liver with the anterior abdominal wall, that is forming the falciform ligament of the liver. Now, in the dorsal mesogastrium, there is development of a spleen, and this dorsal mesogastrium is attached to the greater curvature of the stomach. So because of development of the spleen, the part of the dorsal mesogastrium which is present between the spleen and the stomach is known as gastrosplenic ligament, and the part here which is present between the spleen to the posterior abdominal wall, it is known as lienorenal ligament. Changes in the mesentery here because of rotation. Now you can see this is the lesser omentum which is attached to the lesser curvature, and this is the greater omentum which is attached to the greater curvature. So lesser omentum is dorsal part of the ventral mesogastrium, and which is present between the lesser curvature of the stomach and liver. In the same way, the greater omentum is the ventral part of dorsal mesogastrium which is present between the greater curvature of the stomach and spleen. So here is the image which you can see because of the rotation. You can see here, this is the gastrosplenic ligament, this is the lesser omentum, here is the falciform ligament. So this is here the ventral mesogastrium, and here is the dorsal mesogastrium. Now, histogenesis of stomach. Epithelial lining and gastric gland of stomach develop from the endoderm of the primitive foregut. Rest of the layers of the stomach, that is muscular and serous coats, they are developing from the surrounding splanchnic intraembryonic mesoderm. Gastric gland appear in third month of intrauterine life. Auxentic and zymogenic cells appear in fourth month of intrauterine life. Now, congenital anomalies associated with development of stomach. First one is congenital hypertrophic pyloric stenosis due to hypertrophy of circular muscle layer at pylorus. Okay, so here you can see hypertrophy of circular muscle at the pylorus. These cause the narrowing of pylorus. These causes consequent obstruction to the passage of food through the pylorus. Newborn appears normal at birth, but 2-3 hours after the feeding there is forceful progressive projectile vomiting, and epigastrium shows distension of stomach. Vomit does not contain bile. This is the most important thing. Projectile vomiting and vomit does not contain bile indicates it is congenital hypertrophic pyloric stenosis. Clinically, it presents as an enlargement of abdomen with palpable mass in right hypochondriac region with visible peristalsis, and it can be surgically corrected. Now, development of part of duodenum which is developing from the foregut. So, duodenum developed from two sources. It is having dual origin. The proximal half here, that is first part, and the upper half of the second part, where till the opening of the common bile duct, this is developing from foregut, and the distal half, that is from the lower half of the second part of the duodenum, third part and fourth part of the duodenum, they all are developing from the midgut. So developing duodenum forms a loop attached to the posterior abdominal wall by a mesentery called mesoduodenum. So you can see here, this is developing duodenum. It is having its mesentery which is known as mesoduodenum. The loop is present in sagittal plane. Its apex is Here you can see apex is present at the junction of the foregut and the midgut. This is the apex of the mesoduodenum, and the clockwise rotation of stomach to the left makes the duodenal loop to fall on the right side. The mesoduodenum is absorbed by process of zygosis and duodenum becomes retroperitoneal. Mesoduodenum persists in relation to a small portion of duodenum adjoining the pylorus. So the initial part of the duodenum belonging to the first part of the duodenum, first 2 cm of the duodenum, which is adjoining to pylorus, it has its mesoduodenum. This part is seen in X-ray as a triangular shadow, and this is known as duodenal cap in barium meal study. Initially, development of lumen of duodenum is obliterated by proliferation of endodermal cells. Later, these cells in lumen disintegrate and duodenum gets recanalized. Proximal half developed from the foregut, so it is supplied by artery of the foregut, that is celiac trunk, and distal half of the duodenum, because it is developing from midgut, so it is supplied by artery of midgut, that is superior mesenteric artery. Congenital anomalies of duodenum. First is duodenal stenosis. Obviously, it is because of incomplete recanalization of duodenum. Cells in the lumen disintegrate only in the small central part, producing a narrow lumen, commonly affect third and fourth part and produce partial obstruction. Then there is duodenal atresia. Here you can see atresia. Atresia means due to failure of recanalization of duodenum, and nearly always occur just distal to the hepatopancreatic ampulla, but occasionally it involves third part of the duodenum also. So atresia means there is no formation of duodenum here. Okay, so clinically it present in infant with duodenal with vomiting which begin few hours after birth, and here vomit almost always contain bile. So this is bilious vomiting, and there is a double bubble sign seen on X-ray, abdomen or ultrasound, which indicates duodenal atresia. So you can see double bubble sign. Okay, so how to differentiate between congenital hypertrophic pyloric stenosis and duodenal atresia? In the former, there will be projectile non-bilious vomiting, but in case of the later, in case of duodenal atresia, there will be the vomiting will contain the bile. Then there is duodenal diverticular. They are seen along the inner border of second and third part of the duodenum. They are pouch which are attached to the duodenum. They can be two type, extramural or intramural. Extramural means outside the wall, outside the muscle layer. Intramural means within the muscle. These are the references, and thank you.